Hello again to everyone, and welcome to the Down Syndrome Center of Western Pennsylvania podcast. As always, I am your host, Dr. Kishore Velody. Today, I am grateful to have Dr. Peter Wearden join me on the podcast. Dr. Wearden is a pediatric cardiothoracic surgeon here at Children's Hospital of Pittsburgh. Pete, thanks for joining us today on the podcast. Could you please give us a brief background of your training?
Yes. I grew up in Morgantown, West Virginia, and I trained in, at that time we had a complete training in general surgery first, so I trained as a general surgeon. I then came to Pittsburgh and trained as an adult heart surgeon. I then went to Toronto, Canada, and trained at the Hospital for Sick Children as a pediatric and congenital heart surgeon.
Okay, well, that's a lot of training, and we're glad that it eventually brought you back here to Pittsburgh. As you know, we had Dr. Russo on for our last podcast, and she filled us in on the most common cardiac issues in Down syndrome from her perspective. If you don't mind, could you please give our listeners a brief overview of the common issues with the heart that you see in Down syndrome?
The most common things that we see are holes between the chambers of the hearts. A hole between the top chamber of the heart we call an atrial septal defect. A hole between the bottom chamber of the heart we call a ventricular septal defect. And the septum is sort of the wall. It's the term we use to describe the wall between the chambers. Very common in children with Down syndrome is what we call an atrioventricular septal defect or a complete canal defect. And sometimes we call this an AV canal defect. And that's a hole, it's really one hole, but it's essentially a hole between the top chambers, the bottom chambers, and where there's supposed to be two heart valves, there's only one heart valve. Other conditions that we treat in kids with Down syndrome would be tetralogy of Fallot and also patent ductus arteriosus.
Thanks. So if a baby has one of these conditions, what's next? Do they rush immediately to surgery, or is there a period of waiting?
Generally, there's a period of waiting, and it's always some decision-making as to the appropriate time for surgery, and a lot of it depends upon how the child is doing. So we'd prefer to wait for many of these things for 2, 3, 4 months of age. Occasionally our hand's forced based upon their condition, and we need to operate sooner. Some of these defects may actually even close on their own and not necessitate any surgery, in which case we would just watch them very carefully, making sure that the children don't get into any sort of trouble with their heart, and hope that these holes could close on their own.
A question that comes up frequently in my clinic from the parents is, well, why wait? I mean, after all, if you know they have a heart condition that will need surgery, why not just go in and do that right away?
Well, I think that's a good question. Most of the time, the kids will do a little better if we've waited a period of time. Sometimes I like to tell the parents that they like to be on Earth a little while before we drag them into the operating room to fix these conditions. And so generally, by 3 or 4 months of age, they really do better than they would in the first month of life. That's not to say that we don't operate on many children in the first month of life, and they do fine too. But for instance, they may end up staying in the hospital 2 weeks, where the same operation done on a child at 4 months of age, they may be in the hospital for 5 to 7 days. So really the advantages of waiting is just for them to become a little bigger and perhaps a little more mature physiologically.
That makes sense. Well, could you fill in our listeners on how exactly the decision to do surgery on a baby is made?
So one of the great things about our Heart Institute is we truly function as a team. And so while you may see the cardiologist and then the cardiac surgeon, behind the scenes we've all talked together about the patient. The patient may see the cardiologist, an echocardiogram may be done. We meet once a week and we discuss all of the patients under our care as to the appropriate timing of surgery. Sometimes a child's born and there's not the time for the week to go by for the conference to be held, in which case several of the cardiologists and the cardiac surgeons would meet in an ad hoc basis to discuss the patient. And again, a consensus is formed as to the appropriate timing of surgery and what the appropriate surgery is. So really it's never a decision made by one doctor in isolation, but really as a team of doctors caring for the child.
Can you give us an idea of what might make the cardiac team more concerned about a patient? What would make you want to operate sooner?
So what happens in these patients is the time approaches for surgeries, they essentially develop heart failure. Not quite the same heart failure that we think of in an adult, and certainly not a heart failure that cannot be reversed. But if you think about it, for a baby, things like eating are the most exercise they do. So if their heart's not working as well as it could, they may eat and they may become tired. They may stop eating because that's exercise for them. And along those lines, the other things we watch for is their inability to gain weight. They're not putting on weight at the rate that we'd expect them to. Sometimes these holes in the heart cause too much blood flow to the lungs, and it can keep the lungs wet, as we call it. And those kids may be more prone to respiratory infections and so forth. But all of those things would be the things to look for. But really, it's common sense things. You can tell if your baby's continuing to get better and move along the right track, or if they seem to have plateaued or maybe even worsened a little. It's all fairly obvious things.
That's good to know. Okay, well, let's say the decision has been made for the surgery and the date is set. What can families expect on the day of surgery?
Sure, that's another good question. Obviously, that's a day of high anxiety for the families. And so we usually start in the operating room at a certain time, and they will ask the families to have presented themselves to the same-day surgery center approximately 1 hour prior to that. The nurses will have then meet the family, review some things with them, go over any of the tests, blood work tests that may have been done in the outpatient setting. Usually, depending upon the child and their age, they may receive a pre-anesthetic or a little bit of medicine to calm their nerves. Almost always, you'll meet one of the surgeons before you go back to the operating room. And the surgeons will come and again review the procedure that's going to be performed on the child. And it's one last chance to ask any questions, either of the parents or other family members, if there are any. At Children's Hospital of Pittsburgh, the parents are welcome to accompany their child back to the operating room at the time of surgery. The parents would be asked to put on what we call a bunny suit, which is a funny name for a white suit that they'd wear over their clothes because of the sterile environment of the operating room. And they could accompany their child back to the operating room. And then generally in pediatrics, the children go to sleep with the inhalational anesthetic at that point in time before there's any needle sticks or anything like that. Once their child's safely asleep, the parents leave the operating room, and then the anesthesiologists begin preparing the child for the surgery. And this includes the insertion of some special IVs, generally one in the neck and one in the wrist, so that we can more acutely monitor the blood pressure and other cardiac function during the surgery. Once the child's all ready for surgery, they will have a sterile prep done, which is usually a betadine or chlorhexidine prep, and then the patient's draped. At that point in time, the surgeon would begin the operation. We always have a timeout first, and again, everyone in the operating room reviews the planned procedure and agrees that is what we're planning to do on that child. And then the surgery gets underway at that point.
Well, thanks for that walkthrough. Could you now give us a broad overview of what happens during the surgeries?
Certainly, cardiac surgery is a very unique thing, and in some ways a kind of miraculous thing, because I do have to stop the heart, open the heart up, and go inside there and patch these holes. The way we approach this is we open the breastbone or the sternum down the middle, so it's a straight incision down the middle and the bone's open. A retractor is inserted to open the chest, and then we place the child on the heart-lung machine, and this is done by placing cannula or tubes into the aorta as well as into the superior vena cava and inferior vena cava, where the blood or unoxygenated blood drains back to the heart. So if we take all of the unoxygenated blood from the heart and it goes through our heart-lung machine where it receives oxygen and comes back to the body, at that point in time, the child's heart and lungs can be excluded from the circulation. They no longer really have to be doing anything because the heart-lung machine is doing all of the work. That allows me to administer a high potassium solution to the heart, and we give it a fancy name called cardioplegia. And potassium basically causes the cells in the body to what we call depolarize, which means the heart cells will not contract at that point in time. And so with the heart stopped and a clamp on and no blood going into the heart, I can now open it, There's no blood in there, so I can see, and we can see the holes and patch them. Once we're done, we close up the heart. We allow the blood to enter the heart. We are very careful to make sure that we get all of the air out of the heart before we allow it to beat again, because we would not want any air to go to the brain, which could cause a stroke, which is one of the risks of heart surgery, albeit very small. And it is fascinating to watch as the high potassium solution is washed out of the heart immediately and every time begins to beat again.
Wow, that really is amazing when you step back and think about it. Now, after the heart starts beating again, then what happens?
So once we allow the heart to beat again, we always do echocardiograms again in the operating room to make sure that we have achieved the intended result. And in the echocardiogram, it demonstrates that everything's okay and we've repaired everything that we've set out to repair. We then close the child's chest. We leave behind some temporary pacemaking wires and some what we call chest tubes. The blood has to be completely thinned to go through the heart-lung machine, and there can be some bleeding for a period of time after the surgery, so those tubes remove that blood until the bleeding stops. And then the child's brought out to the cardiac intensive care unit. Generally, we try to what we call extubate all of the children prior to going to the cardiac intensive care unit, and that means remove the breathing tube from their throat. So I would say about 80% of the time I would expect the parents to see their child off the ventilator when they see them in the cardiac ICU unit. It can still be extremely overwhelming, and as a parent myself, I can't imagine what it would be like to see your child connected to these tubes and wires. They also frequently have become swollen. The heart-lung machine causes a side effect of inflammation and swelling. That goes away over the next couple days. And so when they first see their child in the ICU, there will be usually a chest tube, some temporary pacemaking wires, perhaps a ventilator, and then obviously some swelling from the time of surgery. So then at that point in time, the cardiac intensive care unit doctors begin to care for the child. Of course, the surgeons remain involved throughout this time. And over the next several hours, as they recover from the surgery, things begin to settle down. The nurses will adjust their sedation and pain medicine to keep them comfortable. The parents can, after about a half an hour, go back and be with their child and remain with them continuously if they care to do so. And then over the next 24 hours, the recovery begins in earnest. Quite frankly, these children bounce back far more quickly than most parents expect that they will. And really, by the day after surgery, they're starting to come around to seem like themselves again. At this point in time, if they're able to take liquids or solids by mouth, we begin to feed them. We can begin to remove some of the special tubes and wires. Usually by the second day after surgery, they may have left the ICU and gone to a regular floor bed. At that point in time, the amount of recovery is variable, and it depends upon the child and the heart lesion that we corrected. But most of our patients have left the hospital by 5 to 7 days after surgery.
All right. Well, how about after they leave the hospital and then they go back home? Are there any precautions that the parents need to be aware of during that stage of recovery?
So this is a very common question and concerns of the family, and I always tell them that really there's not much the child or they can do to hurt them at that point in time. Everyone's very concerned that we'll do something wrong and we'll hurt the child. That's really not the case. The children, in fact, limit themselves by their discomfort. So if they do something that causes them discomfort, they'll stop it. Generally, the operation will take the wind out of their sails a little bit, and so they're not quite as active as they were before surgery, but within a week or so, that has returned to normal. The only thing really that has to heal is the breastbone or the sternum. It's been wired together with stainless steel wires. It's a bone just like an arm or a leg, and so it heals in the same fashion. If we broke our arm and leg, we'd have a cast for 6 weeks or so. We can't put a cast on the sternum, so we use the wires, and the wires remain forever, but it takes about 6 weeks or so for the bone to heal. So in older children that may be riding a bike or something, we ask them not to do so for 2 months until their sternum has fully healed.
What about for an older baby who might roll over and onto their chest? Is that a concern for their breastbone healing?
Generally, no, that's not a problem. We use a liquid bandage on the incision, so the incision's protected. After a week or so, the liquid bandage begins to look like a peeling sunburn, and it can peel off. We do tell the families to leave them on their back and have no real tummy time until they see the cardiologist, and they would generally see their cardiologist about 2 weeks after surgery, and at that point in time, they can go back to being on their stomach.
Okay, thanks. Now, what about for long-term issues? Do the children ever require a second surgical repair?
So there is from time to time things that happen, and I tell all the families that we should always be cognizant that the child has a repaired heart. And while we hope it is perfectly repaired, it certainly is a repaired heart, and so it should be followed by their cardiologist at the interval that they recommend. But generally this is once a year or once every other year. Nothing really happens quickly or acutely. Many families are afraid that something will happen very fast, but most of the things that we see that come up as problems requiring second surgeons happening very slowly over time, and it may be something that's discussed for several years even before they proceed to surgery. Most commonly in a child with Down syndrome, that would be regurgitation of the atrioventricular valves in a complete AV canal defect. And so if you remember, I said that in that condition, really one valve is turned into two valves. And at the time of surgery, we want it to have as little leak as possible. Some of these children, and it's reported in the literature, about 10% of kids may need a second operation to repair leaking of those valves, particularly the left-sided valves. We currently really strive to decrease that, and I think in our practice it's probably less. But there is the chance that a child with an AV canal defect could need surgery in the future to further repair the valve. With tetralogy of Fallot, a similar condition happens in that when we patch the outflow of the right heart, there's no valve small enough to put in where we put the patch. And in the process of patching, we render the valve that they were born with unusable. And while many people have lived 40 or more years without having a valve there, I think as time goes on, we realize that there was a reason that we were intended to have a valve there in the first place. And so many of these kids would need valve replacement surgery, but not really till their late teens or 20s.
Thanks. Well, Pete, we've reached the end of our podcast. This has been a really informative podcast. Thanks for joining us today.
Thank you. I appreciate the opportunity, and these are wonderful kids and families to care for.
I couldn't agree more. Well, thanks again for sharing your time with us. And families, please stay tuned for our next podcast. Until then, send us any questions or requests to downsyndromecenter@gmail.com. Bye for now.